we have discussed the reason behind the management of diabetes. Why should we treat diabetes? So today we are starting with the management principles of diabetes. We have discussed previously that diabetes is a chronic metabolic disorder characterized by hyperglycemia. There are different types: type 1, type 2, gestational and other specific types. Keep this prevalence blank to discuss a little bit. Today, at the 2023 data, India has 90 million of diabetes population, and it is expected to be 157 million by 2050. And today, the prevalence rate is 10.3%. The most problem part of this spectrum is that almost 43 to 45% of diabetic populations are undiagnosed, and they are gradually proceeding to the different diabetic complications. So, it is obvious, I have mentioned in the first class also, the task for the medical professionals are defined. How to tackle this diabetes menace. Goals of diabetes management: to keep diabetic control by keeping HbA1c less than 7. Some Western countries, they have made it 8, but still our Indian Diabetic Association is maintaining that we must keep it less than 7. What does this HbA1c less than 7 mean? Do you have any idea? HbA1c 7 means in the last 3 months, the diabetic blood sugar level was maintained around 138 to 140 levels. More specifically, now the term TIR, time in range, which is measured by continuous glucose monitor, CGM, and to see that blood glucose level throughout the day, almost 70% time it is within normal range. So, time in range 70% correspond with HbA1c 7. So, there is a variations of the blood glucose level throughout the day, but 70% is a cutoff. So, 70% time in range corresponds with HbA1c 7. Okay. Also, to manage cardiovascular risk factors, other risk factors is associated comorbidities, that is blood pressure, dyslipidemia, and to prevent microvascular and macrovascular complications and improve the quality of life. Any metabolic complication management starts with lifestyle modifications. We all here who very casually say the first term is lifestyle modifications. In question papers also we see everybody writes lifestyle modifications. What is lifestyle modification? Is it something coming from the sky, new thing? No. Lifestyle modifications means going back to our elder persons which they used to. Daily activity, diet and all. We have aberrated from the usual practice of daily life management from our ancestors to now newer generations, having craze for fast food, sedentary lives. Whenever we want, we are not going to market or post office or bank. We are doing online business, everything. So our lifestyle habit has been changed considerably, and going back to that ancestors era in lifestyle management perspective is lifestyle modification. Now what are we have to do? Medical nutrition therapy. Medical nutrition therapy is a designated term which is meant for specific target on the dietary management. Nutritionist, Indian Council of Medical Research and Institute of Nutrition India, they all formulate a guideline based on the regional choice of food, BMR, glycemic load, glycemic index. We have to follow this. Here one thing is very important: glycemic index and glycemic load. Glycemic index means how much glucose or carbohydrate will be generated from the diet is glycemic index, and glycemic load is how much amount we are consuming of that particular food and what is the outcome. This is glucose glycemic load. So a sweet, say Rasagolla, has a high glycemic index, and if you are taking a part of it, so your glycemic load will be very less. This thing you have to adjust, calculate. So in diet, if someone is very much obstinate to have a glass of tea with sugar, we are telling that don't take sugar. Why sugar? I have mentioned previously, 1 teaspoon of sugar means 6 grams of glucose. And the total sugar in our body is 6 grams. So with consuming 1 teaspoon of sugar, we are just doubling our blood sugar level, total blood sugar level. So this is our restriction. But if that person is very much eager to have a tea, so we have to tell that you have to adjust from anywhere else. Say you take 2 chapati less. So this is the adjustment, flexibility in the management guideline, so that patient is happy, and if the patient is not compliant or is not coming back to you, what is the use of giving treatment guideline? Calorie restriction. There are different types of calorie diets. Say at your age, highly active, normal BMR, normal activities, we should advise for 1800 calorie per day, kilocalorie per day. And those who are athletes or bodybuilding experts or doing high muscle training, they will be given 2400 kilocalorie. Those who are sedentary, lie in the bed, 14 to 16, and those debilitated conditions, not bedridden, will restrict 1200 calorie. So this is the variations we made according to their need. There are balanced diet where carbohydrates should be at least 40%, protein 30%, fat 15%, and rest is minerals and fruits. There are many types of diets: keto diet, DASH diet, Mediterranean diets. Keto diet is devoid of carbohydrate, based on only protein and fats and fruits. And DASH diet meant for hypertension. Mediterranean diet is also meant for obesity management. So, our Indian nutrition guidelines says that we should opt for balanced diet. The balanced diet is the optimum goal to maintain. Physical activity, what physical activity? Aerobic exercise. What is aerobic exercise? In physiology, you have read all. What is the types of aerobic exercise? There are, when there is a muscle contraction exercise, weightlifting exercise, that is isotonic exercise, and one is aerobic exercise where walking, jogging, light exercise. This should be 150 minutes per week. So 5 days, 30 minutes workout is possible for everybody, but we don't do it. Resistance training 2 to 3 times per week. What is resistance training? This weightlifting, weight exercise, where we are increasing the resistance of the muscles. Weight management goal. Weight has a very important aspect of management of diabetes or any metabolic complications. 5 to 10% of weight reduction convert fatty liver grade 2 to grade 1, and 20% reductions almost bring down the blood sugar to normal level without any need of medication. So weight management is a very important. Our target is 10%, where there will be optimum need of medication. What are the pharmacological therapy? Have you completed pharmacology? Yes, you know. So oral medications is, to start with, Metformin. Metformin was discovered long back in India, but it was disregarded as a management tool of diabetes by the Western countries, and this was discarded for long. After again they have seen that there is a very important aspect in diabetes management, so they have started this Metformin. What is the basic role of basic pharmacological role of Metformin? It is insulin sensitizer. What is the role of it in the weight management? Neutral. Next is sulfonylurea. Name 2 sulfonylurea. What is the role of sulfonylurea? Sulfonylurea is a secretagogue. It induces the beta cells to secrete more insulin. Glimepiride, glyclazide, Gliperidide, and previously there is Glibenclamide. When we have started our journey, at that time only Glibenclamide was available and Metformin came later. So we have started with those primitive diabetic medications, those who are very potent and very cheap anti-diabetic medications, but the complications was there is a very high incidence of hypoglycemia. Almost clopidogrel and Glibenclamide, almost 30% patients suffered hypoglycemic event in the life. So, newer sulfonylurea, Glibenclamide, the incidence of hypoglycemia is very less. It is in a different study shows it is cardiac safe. It can be tolerated up to 30 expected GFR rate, glomerular filtration rate. Below that should not be given. It one disadvantage is increase the weight, body weight. But it is a very cheap in comparison to the rest of the medications below. Next is coming DPP-4 inhibitors. What is DPP-4? We know we have insulin-like substances in our peptide that is called GLP. So say their accents of these GLPs are very short because these GLP are inhibited by DPP-4 inhibitor enzyme. So these DPP-4 enzyme, So if we give DPP-4 enzyme inhibitor, this will prolong the activities of the GLP-1, and GLP-1 has a very potent anti-diabetic actions. It is again weight neutral. It has a very good cardiac safety and renal safety measures, mostly in the linagliptin. It is a comparatively good cardiac safe drug. Next is coming SGLT2 inhibitors. Here I am going back to DPP-4. There is a term called Incretin Effect. You must know about the Incretin Effect. When a person was given 75 gram of glucose drink orally and simultaneously the insulin is measured. So, it shows that the insulin immediately after taking the glucose meal, there is an increase in the insulin in the blood, normal mechanism. But the same persons when given 75 gram of glucose intravenously through parenteral routes, there is a subdued effect of insulin release. So, this difference between the insulin response to oral glucose and parenteral glucose is called incretin effect. Because when we are taking orally, incretins, this GLP-1, they are taking action during this period. Insulin response is same, but the insulin-like substance response is this incretin effect. You keep it in clear because in your lifetime you will be faced this question in many times. Now SGLT2 inhibitors, sodium glucose, transport mechanism in kidney, reabsorbs the glucose from the renal tubules. So, in normal condition, up to 180 milligram of blood glucose level, we don't get sugar in the urine. This mechanism reabsorb the glucose there. This SGLT2 inhibitor blocks that effect. So, glucose passes through the insulin. Huge amount of glucose passes through the insulin. So, this is a very potent anti-diabetic agent. The glucose carries with it the excess fluid, so it reduces blood sugar. It helps in maintaining the activities of heart. So it is a very important tool in heart failure management. It has a very, positive effect in the kidney. So in kidney failure or kidney, when there is a excess albumin, microalbuminuria in urine, this helps. It reduces uric acid level, again through osmotic diabetes. Triglyceride is also very less. So this is a very important anti-diabetic agent. But one thing to be kept in mind, since there is a increased glucose in the urine, so chances of urinary tract infection is very high. Particularly in the female patients, there is a very common incidence is fungal infections, and in male you have heard the lessons Fournier's ganglion due to fungal infections. Extensive perineal gangrene may also occur. So this is our part in our diabetic management protocol, that we must warn the patient about these complications, that whenever there is any complications, complaint regarding itching, pruritus or dysuria, or in case of male balanitis, immediately he or she should report to the doctors, and this drug may be withheld for a temporary period. Now, injectable agents, GLP-1 agonist, this is used liraglutide, semaglutide. Now, semaglutide is available in India. It is being used as anti-obesity treatment and diabetic treatment. Wegovy, Ozempic, and from 28th March 2026, biosimilars will be available, because these original molecules are costing huge. One injection costs something around at 10,000 rupees, weekly injection. And now the biosimilars are coming with 2,500 rupees for injections. So cost will be sufficiently reduced, but usage should be have a guideline, the guideline protocol, and everybody cannot prescribe this. But still, this medicine is used by the populations from the over the drug counter. They are taking it for obesity management, but there are severe complications of pancreatitis may be there. So everybody should remain cautious about using this medicine. Observe 14th November as Diabetic Day. This is the day when insulin was discovered by Lord Banting. Insulin therapy, there are types: rapid acting insulins, Actrapid, Insuquick, different types of short acting, regular insulin, intermediate acting, insulin N, and long acting. Those were more than 18 hours duration. There are regimens is basal bolus. Basal insulin is that there are two kinds of insulin secretions in our body. One is basal. Throughout the day and night, a low grade insulin is being discharged from the islet cells. And one is pulse generated, related to the food intake. 3 times, morning, afternoon, and in the night. So basal is potentiating the deficiency of the basal insulin, and bolus is when there is a deficit of insulin, we are giving that bolus during the food intake time. Premixed, when there is the short time and the long part is mixed in a ratio 25-75 or 30-75, 30-70 or 50-50 as per need. It is being prefixed and we are giving before the food intake. One part is neutralizing the acting as a bolus and another as basal. Now here the important thing is that we have to know which was in monomer conditions and which are in polymer conditions. So, or dimer conditions. Monomer acts immediately. So, these insulins should not be given 30 minutes before food. This should be given immediately or within 5 minutes of the food intake. And when there is a dimer or polymer, these will go under the subcutaneous, it will be dissolved in the blood, then it will convert it to monomer. So, it will take time, say 20 minutes to 30 minutes. So, that should be given at least 30 minutes. And insulin pump. Insulin pump is a continuous flow of insulin in the system. There are some provisions in the subcutaneous insulin, but commonly it is in the intravenous pump. Where should we give insulin? In normal conditions, other than what are the routes of insulin administrations, rather I will say, most commonly is subcutaneous. How to give and where to give insulin? Abdomen is the most common site, 4 inches away from the navel region, but umbilicus, because that part is very highly vascular. Our aim is to gradual intake of the systemizations of the insulin. So, if we go in a place where there is a highly vascular, it will go to the blood system and it will be dissolved early, metabolized early. We should not give in the intermuscular. We should not give epidermis because it will be unpredictable intake. So, subcutaneous is the area. And when we are giving intravenous, we are intending and designed to give this for a particular purpose. So, subcutaneous and intravenous. There is another route of insulin administration is available, that is nasal, intranasal. Monitor during the management, that is blood glucose and HbA1c. What are how the glucose monitoring is done? One is capillary blood glucose, preferably in the morning before fasting. And when there is a patient is intake, we want to maintain a blood sugar level, so we can take it hourly, 4 hourly, or 3 times as per the need. And HbA1c usually once in 3 months. Management of complications. Microvascular, retinopathy, most important is the prevention. So, regular eye exams, laser therapy, nephropathy, the treatment options are nephropathy. First, I have mentioned yesterday, last day, hyperfiltration, microalbuminuria, albuminuria, then increase in the creatinine. These are coming one by one. So, creatinine, when there is an increase in the creatinine, that is almost the 3rd stage. So, nephropathy, what are the medications we have? ACE inhibitors, ARBs and SGLT2 inhibitors. Neuropathy, very little we can do, but this is the pain management only, and some cases physiotherapy to balance and food care. Balance management is an important part of diabetic neuropathy management because the sensation is lost, and the sensation is one of the important factor maintaining our balance. So we have to maintain balance training is also important. And macrovascular, most important is cardiovascular risk reduction. We have options is aspirin, this is the blood thinner, statins to lower the cholesterols, and blood pressure measurement. Hypoglycemia management, one of the commonest acute complication. 15-15 rule, 15 gram of carbohydrate, wait for 15 minutes, check the blood glucose level. If it is not came to the normal, repeat. And prevention is education, medicine adjustment. Self-monitoring blood glucose, SMBG and HbA1c every 3 to 6 months. Annual complication screening for eyes, feet and kidneys. And one important aspect is patient education and support. Patient, I have mentioned that 43% is undiagnosed. Those have been diagnosed and started with treatment. There is a fallout of treatment of almost 40%. These non-compliant diabetic patients, there may be many reasons. One of the important is that they lack the basic knowledge of the diabetes, why diabetes is important. So make them compliant. Diabetic education programs are very important, and there should be a support groups. They teach each other for the complication management and lifestyle coaching to make them used to the changes in the lifestyle. I have kept the management of diabetic ketoacidosis separately because it is a very important and dreadful complication. If we are not aware of the complicities of diabetic ketoacidosis, we may lose the patient immediately. What is the definition and pathophysiology? Definition is life-threatening complications of diabetes characterized by hyperglycemia, metabolic acidosis and ketosis. What are the ketones of the body? Pathophysiology, there is a insulin deficiency or relative insulin deficiency, high infections. This leads to, since there is a insulin deficiency, glucose is not going inside the cell, so there is a lipolysis and the ketone productions. This ketone causes acidosis in the body, and another is hyperglycemia causing osmotic diuresis, and there is a dehydration. So hyperglycemia, there is a blood sugar is high, but in the intercellular glucose is low. That leads to lipolysis. Lipolysis causes increase in acetone and this ketone body formations due to metabolic acidosis. And another mechanism is that the hyperglycemia induce hyperosmosis of the fluid, so there is a dehydration. Clinical features is polyuria, polydipsia, nausea, vomiting, abdominal pain, dehydration. Kaczynski breathing. Kaczynski's breathing is a acidotic breathing. Altered sensorium. And left findings we will see there is a hyperglycemia, please. Hyperglycemia, metabolic acidosis, ketonemia and ketoniuria. One thing to mention, in a diabetic patient, you may get ketone in some non-diabetic ketoacidosis patients also, when the patient is in SGLT2 inhibitor treatment. Management principles. First thing is that fluid resuscitation. That is severe volume depletion. Patient is very much dehydrated. First, to start with normal saline, then to start insulin therapy, electrolyte replacement, corrections of acidosis, and to identify and treat the precipitating factors. Usually, infection. Fluid resuscitations in initial fluid is saline, 1 to 2 liter over 1 to 2 hours. Very rapid fluid correction. Then maintenance fluid is 0.45%, half saline we say, 0.45% saline. This particular category of patients where this implies very much. If we infuse with normal saline, for the full range of the treatment, there may be intracerebral edema. So that is also a dreaded complications. So after initial volume replacement of the 2 liters of fluid, we go back to half liter. Half liter means we do not want to increase the osmolar pressure of the fluid. And to monitor the urine output and electrolytes and glucose. Here we start with titration of insulin through insulin pump. 0.1 unit per kg per hour IV. Our aim is to reduce the glucose by 50 to 100 milligram per dl per hour. So 0.1 unit means a 50 kg patient will start with 5 units. Then we will reduce to 4, then we will reduce to 3. And our aim is to reduce the glucose by 50 to 100 milligram of dl per hour. And we will switch to subcutaneous insulin when the pH becomes more than 7.3. That is when it is a normal pH from acidosis to corrected acidosis. And anion gap, what is anion gap? Is measured by base deficit by the measurement of the bicarbonate actually. And tolerating oral intake, only then we will shift to subcutaneous insulin. Electrolyte replacement, potassium initially is very high in the blood, but the total body potassium is acutely low. Keep it in mind. This is a MCQ question, mind it. The body potassium level will be low, but there will be high potassium in the blood. Why? Because hyperglycemia does not allow intracellular potassium intake. So it will be there in the outside, and there is volume depletions. So there will be concentrations of potassium will be high, and there is metabolic acidosis. That is also leads to hyperkalemia. But the body, so before starting, whenever we start insulin, insulin will allow potassium to go inside the cell. So if immediately there will be a huge shift of the potassium. So before starting of insulin, we must check the potassium level. So if there is a less than 5.3 milliequivalent per liter, usually 3 to 5 is the normal range of potassium blood. But 5, if it is less than 5.3 in a diabetic acidotic patient, we must replace potassium. Otherwise, there will be a sudden depletion of the potassium in the blood vessels. Blood serum potassium will go down. Bicarbonate, when there is a severe acidosis, metabolic acidosis, when there is a pH is less than 6.9. And phosphate to replace if there is less than 1. Here another electrolytes, if it is present, that is a very grave sign, that is lactate. If lactate increases by 5, the chance of recovery is almost nil. So we have to, lactate comes after the destruction of the cell. So we have to keep the lactase low between less than 2. Monitoring glucose hourly, electrolytes 2 to 4 hours, pH and ion gaps 2 to 4 hourly, and ketones in urine and blood. What are the precipitating factors? I have mentioned mostly infection, non-adherence to insulin, new onset diabetes, and medication by steroids. Now one thing is that this period, the name is called honeymoon periods. That is in type 1 diabetes, the insulin deficiency started, and that is a rise of the blood glucose level. So something around puberty time, there is a slight infection may cause sudden dip in the already available insulin. So there will be a huge surge of sugar, blood sugar in the body, and this infection leads to diabetic ketoacidosis. So in IDDM, very low age group patients may suffer from diabetic ketoacidosis. What is gestational diabetes? Glucose intolerance first detected during pregnancy. And prevalence is 10 to 25% of pregnancies, varies by populations. How do we know that this is the first occurrence? Last day we have mentioned by HbA1c. In the first term of pregnancy, whenever the patient is first coming, we will see HbA1c. If it is normal, but you are getting blood sugar level high, so this may be a gestational diabetes mellitus. Then we take a history. Risk factor is previous gestational diabetes, family history of diabetes, obesity, age more than 35 years, previous history of macrosomic baby, or ethnicity, high risk groups. So screening and diagnosis, universal screening at 24 to 28 weeks, 1-step or 2-step OGTT with 75 or 100. In this OGTT, we measure the blood glucose level every 30 minutes during this 2 hours period. Diagnostic criteria is changed. Here it is fasting more than 92, 1 hour more than 180, and 2 hour more than 153. If this oral OGT is this, then we will consider this is a hyperglycemic state in pregnancy. Management, here again medical nutrition therapy, physical activity, blood glucose monitoring, and insulin therapy if needed. Insulin is a very safe option, but still we can use some other medications also. Treatment goals is fasting less than 95 to keep the blood sugar level, first hour PP in 140 and 2 hour PP by 120. In normal conditions, I have mentioned that 130 is the fasting and 200 is the PP. Here 95 and 120 PP. Postpartum follow-up, 75 gram OGT at 4 to 12 weeks postpartum. Annual screening for diabetes, because these patients are more prone to getting the normal diabetes mellitus, and lifestyle modifications to prevent future diabetes. What are the complications? GDMs, macrosomic baby, birth trauma, preterm labor, preeclampsia, and future risk for both mother and baby to become a diabetic patient.